بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. شكرا جزيلا على الدعوة الكريمة لعائلتي الدائمة my family، وشكرا للجنة المنظمة والدكتورة شيرين والدكتورة إيمان. Okay, I would like to start with my title, which is the hemoglobin methods in clinical practice, lessons from real life cases. I just want to mention that I'm not going to go into depth of the pathophysiology and this kind of and the clinical presentation and so on, because these things are already present in the textbooks. My aim today is to give you a flavor or a hint of the interpretation of the hemoglobin electrophoresis, especially using the capillary electrophoresis, which in my opinion is the best machine or method to clarify the hemoglobin electrophoresis, as it gives very clear bands of the different hemoglobin contents. And also I would concentrate mainly on the adult cases of hemoglobin electrophoresis. Right. The term hemoglobin electrophoresis covers a range of, let's move it here, okay, of conditions with a pattern that affect hemoglobin, including alpha thalassemia and beta thalassemia, sickle cell disease, and other abnormal hemoglobins such as hemoglobin E. Individuals with thalassemia produce insufficient hemoglobin, and this is mandated by reduced MCV and MCH, while those with sickle cell disease produce structurally abnormal hemoglobin, mostly normal CBC. There is a point here which I would like to clarify, which is, broadly speaking, we have two things in the hemoglobin of this. Either structural, in that case, similar to sickle cell disease and CD and so on, there is no deficiency. Almost there is no deficiency, especially in trade cases, in the synthesis of hemoglobin. While in the thalassemia, there is a real deficiency. So in that case, we have a reduced MCV and MCH. It's similar to with iron deficiency, but iron is the deficiency in the heme part, while hemoglobinosis is the deficiency in the globin part. This why, and I'm not sure if Dr. Sharif is around, we emphasize that MCV, we use the international reference standard, not the local standard. Hemoglobinopathies are common preventable monogenic disorders, and the lab often sees the first clue as microcytosis, high red cell count, and abnormal hemoglobin fractions. Capillary electrophoresis is powerful, but interpretation is pattern recognition. Real life cases expose pitfalls that textbook underemphasize. This is what I'm going to show you, inshallah. I usually like a bit of history before we start off. In 1925, Cooley described the severe anemia in children. Later, it is recognized as thalassemia major. Sickle cell disease, first recognized as molecular disease in 1994. A clinical phenotype became linked to a defined hemoglobin abnormalities, and this changed medicine from descriptive morphology in the olden days to a molecular pathophysiology. So, modern interpretation still requires integration of the clinical condition of the patient CBC, hemoglobin pattern, and genetics. Epidemiology, why it's very important to recognize cases of hemoglobinopathies. And I very quite remember that I had started my first supervision with Professor Ahmed Allam and Professor, and he worked hard during his MD thesis on cases of beta hemoglobin, in some cases of hemoglobinopathies. So hemoglobinopathies, primarily beta thalassemia and sickle cell disease, are a major public health condition in Egypt, driven by by high rate of consanguineous marriages. They create severe clinical and financial burden due to life complications and due to iron overload and organ damage. Actually, this is a very important, not only financially, but also on the effect of the lifestyle and life wellness of the patients. And I just want to show you that every single patient costs annually around $10,000 per year, and also even there was a newly discovered treatment for serum for sickle cell disease, and the cost of it was $250,000 per month. Okay, we have, as I said, it's either the hemoglobinopathy is either qualitative or quantitative. Qualitative, it means that there is a structure abnormality only for gene single point mutation, like what happens in hemoglobin S and C and etc. And this is mostly concerning the beta part of the beta genes. And we have a quantitative, in which there is a decreased production of the alpha or beta, and in this case we call it thalassemia. And there is other hemoglobin variants, and also I would like to raise your attention that we have not only quantitative or qualitative, we have some cases which produces polythalassemia rather than anemia. And I will show you a case about that. There are some mutations which produces high affinity for oxygen, and in that case it quantitative. We have alpha thalassemia. Alpha thalassemia, it might present as a silent carrier or trait, or hemoglobin H disease and hemoglobin BART in cases of hydrops fetalis. Hemoglobin H disease, because of the deficiency of alpha chains, consists of 4 gamma chains. And hemoglobin BART, it happens after neonatal life, because again of the deficiency of the alpha chains. There is produced by 4 gamma chains. And also just a hint، يعني أنا بفتكر دايما عشان ما تلخبطش ما بين ال H والبارت. والبارت it means baby. يعني البيتا ثالاسيميا برضو, it's in the production we have trait intermediate and major. We have also delta thalassemia and hereditary resistance of fetal hemoglobin. Structural, as we said before, sickle cell, C, D, E, and other groups. And I will show you cases of these clinical cases of these patterns. Skip because of the time. Here, this is the cases. I will show you an interesting case. I already sent it before on the group on the group of you. You have a group of clinical pathologists with the expertise. I sent this case, and I will show it to you as well. Right. As I said, alpha-like genes. It lies on chromosome 16, and beta-like genes lies on chromosome 11. Adult hemoglobin A consists of 2 alpha and 2 beta, and hemoglobin A2 2 alpha and 2 delta, and hemoglobin F2 alpha and 2 gamma, and these are the only normal hemoglobin which are present in the adults. As you know, beta thalassemia shows an increase in A2 and F, and alpha thalassemia may produce, as I said, up to hemoglobin H for beta, or hemoglobin parts for gamma. And this is the normal concentrations starting from birth, and it's normalized when the patient or the person becomes 1 year old. Just to emphasize here that the normal range of A2, which is very important, is from 2 to 3.5%, and we use this cutoff for the diagnosis of cases of beta thalassemia. We usually use for diagnosis, we have to use the normal way, but there are some hints. When the patient, it's very important to check the patient if the patient has microcytosis. The condition of RDW is very important as well, as it gives a hint if this is just a case of thalassemia or associated with iron deficiency anemia. Peripheral SME, of course, shows target cells, sickle cells, etc. Iron status is very, very important, and ferritin and transferrin. Ferritin is now internationally agreed to increase the minimum amount to 30 nanogram per ml, not like the olden days, whether in male or female. And this is again a hint for Dr. Sharif if he's around. And we use hemoglobin electrophoresis, and I recommend capillary electrophoresis.